My name is Lars Lund. I'm a professor of cardiology at the Karolinska University Hospital in Stockholm, Sweden. So patients with advanced heart failure and reduced ejection fraction, their primary problem is reduced contractility. And we have tremendous treatments today for heart failure with reduced ejection fraction. But what they all do is that they block the progression. None target the underlying pathology, which is reduced contractility. In extreme settings, we use intravenous inotropes, and they do improve contractility, but are otherwise harmful and are recommended only in rare settings. We've developed a new treatment concept based on the endogenous Ghrelin peptide, which we believe has the potential to improve cardiac contractility and improve cardiac output, and thus have a good potential in acute and advanced heart failure. And we believe that this concept will not have the same adverse effects that traditional inotropes do, and therefore our treatment concept and our mode of action may be suitable for long-term and chronic use. So we hope to improve cardiac output, quality of life and symptoms and outcomes in patients with heart failure, reduced ejection fraction of moderate to severe degree. So ghrelin is an endogenous peptide. It's secreted by the stomach and it acts primarily by stimulating appetite. But we and others have shown that it also has vascular and direct cardiac effects. And in preclinical studies, we do have some hints that it might act in a favorable mechanism without inducing calcium, which the traditional inotropes do, but instead by increasing the sensitivity to existing calcium, which would not be associated with ischemia, tachycardia, arrhythmia. Yeah, this is a double-blind, placebo-controlled, randomized trial of ghrelin given for 2 hours intravenously or placebo given for 2 hours intravenously. Patients were ambulatory New York Heart 3 to 4, so moderate to severe heart failure but not in the hospital. An ejection fraction of less than or equal to 40%, so moderately to severely reduced ejection fraction. And they spent 1 day in the hospital where we performed multiple investigations before, during, and after this treatment. So multiple biomarkers and PK and PD assessment, of course, but with the primary endpoint measure or primary outcome measure being change in cardiac output. The results showed that on this primary endpoint, in this randomized trial, ghrelin increased cardiac output from a little above 4 to above 5. It normalized cardiac output to more than 5 liters per minute, whereas the placebo group remained flat at approximately 4 liters per minute. So this is a very clinically meaningful effect, highly statistically significant, and provides great promise for this treatment concept to be developed further. Given this very positive effect on cardiac output, the immediate worry is, number one, is this associated with some harmful effects? But there was no hypotension, no tachycardia, no arrhythmia in our study. And when we went to the lab and studied in beating ex vivo cardiomyocytes, we showed that the reason there were no clinical side effects is because indeed it does act through calcium sensitization rather than inducing increased calcium transients or calcium concentrations. So this explains why in the clinical study we didn't see side effects. Furthermore, an important mode of action of most inotropes is that they are actually inodilators, so they act to a great extent by dilating vessels, reducing afterload, and making it easy to increase cardiac output without actually increasing the force of contraction. But in our experimental setup, cells are beating in a load-independent fashion, and we observed that they increased their fractional shortening. They contracted faster and better, even in the absence of vessels, either as a preload or afterload system. So the findings taken together suggest that we increase the force of contraction, contractility, cardiac output through calcium sensitization and without being dependent on a reduction in afterload. Very promising for clinical future studies and applications.